I'm Dr. Tahira and you're watching program Health is Wealth. May 3rd is celebrated as World Ankylosing Spondylitis Day. Rheumatology is very common, but unfortunately, rheumatologists are not as common and we don't understand much about the disease. That is why today we are going to discuss in detail all rheumatological disorders, including ankylosing spondylitis. Assalamu alaikum, welcome to another episode of Health is Wealth. Today is World Ankylosing Spondylitis Day. It is celebrated on May 3rd. We are celebrating it today. And the importance of this disease, what exactly is ankylosing spondylitis, what is rheumatology, who is a rheumatologist, when do you need to identify your symptoms and how do you need to go about them. Today we are going to discuss in detail with our consultant rheumatologist. Thank you so much for joining us, Dr.Uzma Rasheed. Thank you so much for joining us today. We will be discussing in detail all about these diseases, all about rheumatology. But let us start first with ankylosing spondylitis and then we will go on to everything else. So what exactly is this disease?
Ankylosing spondylitis is a disease which affects the back and the large joints. It is the disease which usually is seen in young patients as compared to the general concept that back pain usually affects the elderly people. So, the young people are affected and this is an inflammatory disease which affects your spine and the big bones which connect the pelvis to the spine. Okay. So, it is the disease of that joints.
So when we say disease of the joints, we had this notion, preconceived notion that we need to go to an orthopedic doctor or an orthopedic surgeon, and then we keep going and we keep going in circles around them and we don't ever go to a rheumatologist. Why is that? People don't have an idea about who is a rheumatologist and there are not many rheumatologists around, and how is it that a rheumatologist is different from an orthopedic surgeon?
So, thank you so much for this very important question, because rheumatology is not a very old field, it is a new field and there are not too many rheumatologists in the Pakistan. Basically, rheumatologists are the doctor who treat the diseases of the bones, the joints and the muscles, and these all diseases, either they are inflammatory or degenerative, these are treated by the rheumatologist. So, another important question is that what is the difference between the rheumatologist and an orthopedic surgeon? So, rheumatologist is a doctor who treats the patient with medications, who treat these diseases of the muscles, bones and joints with the medicines. But orthopedic doctor is a doctor who treat the diseases of the bones with surgically, like fracture fixation or joint replacements or knee replacements. So, this is basically the difference of the orthopedic and rheumatologist.
So, basically if somebody has a backache and you said it's a young person and they are not, they didn't have any trauma as such, so they should suspect that they are having ankylosing spondylitis and go to a rheumatologist. Now, when they go to a rheumatologist, what are the symptoms that a rheumatologist looks for? What are the complaints of the patient as such, and then what are the investigations ordered?
So, first of all, the ankylosing spondylitis, usually it is the most common symptom is the backache, which usually most of the people come across during their lifetime, and it has been said that each individual has 80% risk of having backache at some point in time in their life. Yeah. And out of these 80% of the patients, 90% of them recover and they don't grow into chronic phase, that is not more than 3 months. Their backache settle within 3 months. And out of these, those who progress to chronic backache, those who have back pains for more than 3 months, they are said to have chronic backache. Out of them, a few of them have ankylosing spondylitis. So, those patients who have backache at younger age, less than 45 years of age, especially younger age, having backache more than 3 months, and the backache is typically inflammatory, like the pain is aggravated by rest, which is contrary to the normal backache, usually which increases on exertion. So, it increases on rest and it improves with activity, especially when these patients find themselves problematic, or they get up in the mid of the night, because of the pain, and it becomes difficult for them to turn side in the beds. And especially when they get up in the morning, they have morning stiffness, that their back feels stiff and it is difficult for them to move, and this stiffness lasts for more than 30 minutes.
Okay.
And
And
this
with
is how,
activity it gets
and
better?
with as the day passes, the patient starts feeling better.
So what are the investigations? Like, for example, do we need an X-ray, MRI? What is the diagnostic factor or other blood tests that would tell somebody that, yes, I have ankylosing spondylitis and not anything else like osteoarthritis and the others?
So, the ankylosing spondylitis, basically half of its diagnosis lies in the history, the way the doctor evaluates you and ask you about your symptoms, the specification of their symptoms, that they are inflammatory pain, and then in the light of the history, and there are some certain risk factors, like if someone else in the family have the ankylosing spondylitis, or someone else in the family have psoriasis or psoriatic arthritis, or someone have inflammatory bowel diseases like ulcerative colitis or Crohn's disease, someone have got red eye disease, which is called anterior uveitis. So all these patients who have these risk factors, in the background of these risk factors and the specific symptoms, the doctor evaluate you and then order you investigations, which includes first of all, the X-ray is the first step in the management. If sometime it is seen that X-ray do not pick up the disease in the early phase. So in these patients, if there is a strong suspicion of ankylosing spondylitis, the doctor orders MRI that picks up this disease in very early stage. And this is.
So how does it present on the MRI? Does the fusion show like actually the spine is fusing into the pelvis? Because in other things, for example, in osteoarthritis, you can see spurs and you can see some erosion. In osteoporosis, there is, the density is decreased and everything. So how does this ankylosing spondylitis present on an MRI? How would you know that?
On an MRI. First, I would like to tell you that what it looks like on an X-ray. On X-ray, there is the fusion of the joint, that is syndesmophyte formation of the major sacroiliac joint, that is the joint which connect the spine with the pelvis. So there is a fusion of those joints, and then gradually these vertebra, they become fused with each.
And this is not surgically corrected, it is impossible to correct it surgically?
The surgery is usually not very preferable. The recommendations are that to keep the surgery at lower threshold, higher threshold for the surgery, and you go for medical treatment. So these findings of fusion of the joint is seen on X-rays in a very advanced stage, but in MRI you pick up the edema signals, which radiologist can say that there is early inflammation, that is before the fusion of the bones. So MRI is very important in picking up the disease very early before the fusion has occurred. So there is a time. So there is a time window of opportunity to treat these patients, and so that they can be prevented from disability and chronic pain.
So you said this is an inflammation, but what is the reason for this? Is it genetic? Is it autoimmune? And you clubbed it with a lot of other autoimmune diseases as well, right? So what are the patients, who are the patients who are more prone to it? You did mention a few risk factors, but who should be on the lookout for this, and who would you, group as people who are, most likely to get it?
First of all, coming to what is the cause of this disease? The cause of this disease is usually they have some genetic background. For example, they have some genetic changes, like they are positive for HLA-B27, that is a gene which can be identified, and it is not likely that all those individuals who have this HLA-B27, they have ankylosing spondylitis. Only 5% of those who have HLA-B27 have ankylosing spondylitis. But once you screen the patient who have ankylosing spondylitis, 80% of them turn out to have HLA-B27. So they have in the background of genetic disease, either it is triggered by some infection, or bacteria enters the bloodstream and then it triggers the immune process and leads to this inflammation of the bones and joints.
So how exactly is ankylosing spondylitis different from osteoarthritis and from rheumatoid arthritis? And in rheumatoid arthritis, they say we do the RA factor and all of these, and you said HLA-B27 is the gene that is responsible. So is this gene responsible for these other rheumatological diseases as well, or is it specific to ankylosing spondylitis?
Thank you so much for this question. How it is different from rheumatoid arthritis and osteoarthritis. It is different from rheumatoid arthritis because it primarily involves the spine and the big joints. the axial joints like hip joints, like shoulder joints, knee, and the joints of the spine and sacroiliac joints. But the rheumatoid arthritis basically involve these small joints of your hands and other small, and even it can involve the large joints. It involves them symmetrically. So it is basically, sometimes in ankylosing spondylitis these small joints are also involved, but basic difference between them is that both of these are inflammatory condition, both of these are chronic condition. But in ankylosing spondylitis, back and spine and large joints are affected, and in rheumatoid arthritis usually the small joints of hands and feet are affected. And how it is different from osteoarthritis: osteoarthritis is usually a degenerative disease, or it is related to age related changes which are wear and tear arthritis, and it is usually seen in elderly patients. And ankylosing spondylitis is usually seen in the younger patient, less than 45 years of age. So this is with osteoarthritis the difference of age, and with rheumatoid arthritis there is a difference of which type of the joints are involved in the disease.
You said that infection plays a role, and infection and genetics could play a role in leading to this inflammation. How much does posture and your lifestyle also play a role in this?
The posture does not play a role in this, but once you have ankylosing spondylitis, we tell them to have posterior adoptive condition. This is basically the inflammatory or autoimmune disease which affects, it doesn't have these something relation to diet or anything else. The infection which I mentioned is still unidentified, that which sort of infection lead to all these, trigger the autoimmune process which lead to the inflammation of the joints.
What is the management of ankylosing spondylitis? How do we manage it? What are the medications that are advised, and is it physiotherapy? What else is there?
So in the management, first lies the non-pharmacological measures which are not related to the medicines, and then pharmacological measures. In non-pharmacological measures, lifestyle modifications, patients are advised to be more active, they need to exercise, and they are advised to quit smoking because smoking has deleterious effect on the disease, and they are advised to have light exercises, daily walking. And in addition to these lifestyle modifications, we also advise the medications. So in medications, first of all, the non-steroidal anti-inflammatory agent, which are the anti-inflammatory agents like commonly used ibuprofen, diclofenac or naproxen. We used to give them for 2 to 3 months, and then monitor that whether the patient is responding to these medications or not responding to these medications. And if the patient is not responding to these primary anti-inflammatory medication, then we move on to biologic agents, which are the new medications in field of rheumatology. And these are the medications which control the disease, delays the structural damage, improves the pain, and improves the quality of life. These are the newer agents, and these are alhamdulillah available in Pakistan. Most of the biologics which are used to treat ankylosing spondylitis, they are available in Pakistan, and these includes the etanercept, infliximab, adalimumab, and secukinumab, IL-17 inhibitors. In addition to that, JAK inhibitors that are targeted synthetic DMARDs in the form of tablets. They are also available in Pakistan. So once the patient do not respond to the first step, they move on to the next step, which is the biologic therapy.
Okay, it was known that these disease-modifying drugs in the past, the immunosuppressants, like for example methotrexate and the conventional ones that we used to have, they used to have a lot of very severe side effects with the nausea and with severe immunosuppression. But these newer biologics apparently seem to attack only the selective, the antibodies that are responsible for it. Is that true? Are these safer than the ones we used to use in the past? And do you advise them by and large to the whole population, or do you tell them to just go buy painkillers?
So first of all, I would like to tell you that the methotrexate usually does not have any role in these ankylosing spondylitis.
No, I'm talking about the others as well.
The other diseases.
Because these biologics cover a number of diseases.
They are used in rheumatoid arthritis and many other diseases. So the conventional synthetic DMARDs like methotrexate or leflunomide, which you are mentioning, that associated with the side effects. The biologics are not associated with these nausea, vomiting, and other side effects. Both of them have a bit of different infection and side effect profile. So with the biologics, we come across different side effects like infections that are sometimes in the form of tuberculosis, hepatitis B and C. These infections get flare up if the patient already have got them.
Okay.
So there is a different side effect.
So for how long do you need to keep taking biologics? Because this is an autoimmune condition and it has now developed, right? So you said ankylosing spondylitis is inflammatory, but it has autoimmune connections, right? So for how long do they need to keep taking it, or is it a lifelong thing that they need to?
It's a very good question, and very important, because most of the patients, when they come to us, they have this question in their mind, because talking about the cost of the biologics, it is more than conventional DMARDs which you mentioned, methotrexate and other drugs. So they are costly because we are the resource limited country, and the economic condition of our patients is not very good, and government doesn't cover these medications like in the abroad. They have medical coverage or they have insurance for this. So the cost is a big issue, and the side effect profile is also a big issue. So the patient asks these questions. So once you start the biologics, usually it is said that you have to continue till the disease is controlled for the 6th month. And then it is now in the latest recommendation, it has been recommended that you increase the duration, gradually taper them, or slowly reduce their dose or increase their interval, so that you can keep a balance between the dose of the treatment and between the symptoms of the patient. So it is like a continuous monitoring of the patient by a rheumatologist. Once you are diagnosed with ankylosing spondylitis or any other inflammatory rheumatic disease, you have to be under regular follow-up of the doctor. So this is the most important essence, that you need to have a regular follow-up with the doctor.
And if somebody has ankylosing spondylitis, especially a young individual, and so what are the guidelines for them? Like, what are the professions that they can take for? Should they go for sports, because will it be disabling in the long run? Or what are the, how do they need to be careful? As are they susceptible more to fractures, or easily susceptible to some kind of deformity or disability? Or is it okay if they're taking these biologics, they can continue their lifestyle as normal? And what is the ideal, like, for example, the lifestyle for them in terms of on what kind of mattress should they be sleeping, what kind of chair should they be using, and how should their activity be?
So I'd like to mention that usually there is a delay in diagnosis. The most important essence of celebrating this World Ankylosing Spondylitis Day is to encourage the early diagnosis and to raise the awareness about the early diagnosis. So if the disease is diagnosed in its earlier phase, you can prevent the disability, you can prevent the pain and damage to the joint. So you can prevent it. But most of the time usually there is a delay of diagnosis, like maybe 6 to 10 years, and by that time the patients have already developed the deformities. So for these deformities, you cannot, a common person cannot consider what type of disabilities these patients have. They have problem in tying the shoelaces, they have problem in turning the head and to look into for the traffic signals or things like this. Simple driving or simple picking up a child is very difficult for them. So they have many limitations.
So is there any disease that can slow the progression, any sort of management or medicine that can slow the progression of the disease? Because if somebody at such a young age develops it, then it's very scary, but it's very terrifying for them to think that this is going to keep progressing day by day.
So these medications which I have mentioned, that NSAIDs reduces the pain and also reduces the structural damage, and in addition to that, the biologic, they reduce the structural damage and they prevent the progress of disease.
So early detection is very essential, and then being on medication is. What is the role of exercise and physiotherapy?
Yes, exercise and physiotherapy also have good role, because we should encourage the patient to exercise more frequently, so that they do not develop this stiffness. They should have their stretching exercises. There's a separate it's a separate issue which should be dealt in, and in addition to the medications. So they should exercise regularly, they should have a regular walk, they should avoid smoking, they should eat healthy food,
When we
healthy
talk
fruits,
about
vegetables.
healthy food and nutrition, does vitamin D and calcium, do these play a role in it? Because for joint health, they keep saying it is very essential that your vitamin D is in place, that your calcium, magnesium is in place. So how important are
So
they?
this is also a very important question, because the people think that taking vitamin D will prevent this disease or will cure this disease. But this is very important, that vitamin D doesn't have any role in the progression of the disease or in the cure of the disease. So
It doesn't?
It doesn't have for the ankylosing spondylitis.
Okay,
It doesn't have.
So
any
nutrition doesn't really play a role. And what about the glucosamine, chondroitin, MSM, all of this?
They doesn't play any role in the ankylosing
So you have,
spondylitis.
there's absolutely nothing you can do other than just keep a check on your symptoms and start medication early.
Start medication
with
early,
exercise.
and he eat a healthy diet which is rich in fruits and vegetables, so that your immune system
So basically
is.
you need to boost your immunity, because it's an autoimmune problem. It's going to make your immunity go down. So more and more vitamin C and all of those things will help. So you need to boost your immunity. Okay. So we've spoken enough about ankylosing spondylitis. Let us go to the other joint diseases, because we have so many people around, especially women in our part of the world, suffering from osteoarthritis. So what exactly, how do you stop osteoarthritis from progressing? How do you manage it? What are the drugs?
Osteoarthritis is usually a disease of usually the elderly, but it is now been seen in the early ages, like early 40s or 50s. The people have their knee pain or hip pain, or sometime it also present with the pain in the small joints of the hands, in the back, in the neck. So it is a generalized osteoarthritis. So the key is the exercise and daily walk and the strengthening exercises. And basically you prevent those maneuver which increase the pain or which cause the pain. Like for example, in the knee osteoarthritis, you ask them to avoid the stairs or sitting on the floor, or sitting with the bent knees, and encourage them to have quadriceps strengthening exercises and all those strengthening
exercises. So these
exercises.
biologics or disease modifying drugs are not used for osteoarthritis, only painkillers are, right?
There is no drug which can modify like disease modifying agent for osteoarthritis. It is just the pain management, exercise and management.
So does a rheumatologist also inject joints with, like for example, steroids or hyaluronic acid, or is that under an orthopedic doctor?
Yes, we inject the joint. Sometime with osteoarthritis, the patient have some fluid in the knee. When there is an inflammatory phase of the osteoarthritis, the patient have fluid in the knee, or sometime when it is not responding to the standard of the care treatment, that is painkillers or NSAIDs. So when we can inject the joints, and it has some temporary effect on the pain. Hyaluronic acid gel preparations have been used, PRP has been used, but they are just investigational.
Dry needling, PRP? Now lately people are using some cold laser, some others are using stem cell. They're saying it is stem cell. I don't know how true they are, but all these things, do they help as well?
The recommendations don't recommend these therapies. Alternative therapies like acupuncture have some role, yoga have some role, exercises have some role, but these stem cell therapy saying they are not being recommended by the societies.
But a lot of doctors unfortunately are exploiting people in the name of stem cell and charging them very heavily and doing this. So do you suggest that they don't do this? At least the patients, for the patients, it's very important for them to know via our program that they should not trust.
Patient is when they are in pain, they usually want want to go for any therapy, and if someone tells them that this have effect, then the studies have shown, some studies have shown that they have some effect on the knee pain or this hyaluronic acid and plasma rich platelet rich plasma PRP therapy or some stem cell therapy, but they're scientifically when they are evaluated, they do not have authentically
proven. It's more of a placebo
role.
effect. Anything else would also have that much of effect for that much time, I suppose, right?
Or even a steroid injection can
achieve the same results with the same thing. But they are so scared of those injections that then they
The steroid is a very scary name. Once you speak it out,
even immunosuppressants for a very long time have been very feared. We always are scared that they would destroy our immunity. and make us susceptible to so many other infections. That's why people have been avoiding biologics also in the past. Let us talk about psoriatic arthritis. Because being a dermatologist, I've seen so many cases of psoriasis and people keep ignoring it. As long as it's disfiguring to the face, they are worried about it. But if it starts infiltrating their joints, they start delaying it till it has actually made them disabled. So do you deal with those situations as well?
Yes. Psoriatic arthritis in fact is one of the disease which is grouped under the umbrella of the spondyloarthropathy. One of the component is the ankylosing spondylitis, other is the psoriatic arthritis, then inflammatory bowel disease related arthritis. They are all come under the umbrella of spondyloarthropathy. So psoriatic arthritis is a disease which affects the small and large joint. It can also affect your spine like ankylosing spondylitis. So the patient who have psoriasis, they are at risk of developing psoriatic arthritis.
And deformity and
deformities,
in the long run.
disabilities. They can have the deformities of their peripheral joint. They can have the deformities of their axial spine, which is the axial spine and the large joints of the body. So it can affect in the same way. It can be.
So anybody who is suffering from a full-blown psoriatic attack with psoriatic arthritis involvement should be visiting a rheumatologist and getting their course of either biologics or whatever disease-modifying drugs to control it in time before it gets to the stage of deformity, right? Definitely. Because once it is there, then it becomes irreversible. Let us talk about a few more autoimmune conditions like SLE or lupus. Very little is known about it, and a lot of people are suffering, unfortunately, and they keep being misdiagnosed. People don't know what is this rash, why are they having all of these symptoms. So what exactly is SLE and the investigations for it?
So SLE is another autoimmune disease, which is a chronic inflammatory disease, and affects the usually it affects the young girls in their young age. It is not a disease of the old age. So young girls are affected. They present with either the joint symptoms or they have different sort of rashes on the body, especially the butterfly rash, which is seen on the face in the form of a butterfly. Else they can have the rashes on their hands, on their feet, and these they can have sensitivity to the sun. Their skin get burns, or they have photosensitivity on exposure to the sun. Then they can have excessive hair fall leading to alopecia. Sometimes they have their hands turning to red, the red, blue or white on exposure to cold, which is called Raynaud's phenomena. They can have fevers. They can have any. This is a systemic disease, and it can involve any system of your body. That it can involve the heart, lungs, kidney, or brain. So it is a multi-system disease. So if you have this, if the patient is a young patient, have painful joints, painful swollen joints, they have mouth ulcers which are not responding to any treatment. So and rashes, fever, Raynaud's, they should consult their rheumatologist.
And then there are specific antibody tests for SLE that they need to get, that anti-DNA, anti-SSN.
Yes.
What are those tests?
These are antibodies tests, including ANA antibodies, anti-dsDNA antibodies, and ENA profile. And you start from the baseline. From the blood CP, you can have many findings which can be picked up on the blood complete picture. On urinary, you can have protein in the urine. You can have different abnormalities.
And what is the management for SLE?
Management for SLE is you have disease modifying agents like hydroxychloroquine is usually used in these patients. Every patient of SLE should be on hydroxychloroquine until there is a contact.
The malarial drug?
Yes, anti-malarial drug, which is to be given to every patient of SLE until there is a contraindication or some allergies developed to this
And this
drug.
also is a lifelong condition, or it gets controlled?
Yes, it is a lifelong condition, and you need to be under the follow-up of a rheumatologist so that they can pick up early either any of your organ is going to be involved, so they can take preventive measure and you start.
And you said organ being
medications.
involved, it's a very good subject. We missed it in the ankylosing spondylitis. If it is left untreated, if you let it, how does it complicate and involve all the other organs of the body? For example, the heart or the kidneys, or whatsoever, whether it is ankylosing spondylitis or any of these rheumatological conditions? Do they have a great systemic involvement with the rest of the systems as well, the kidneys and the brain, the heart?
Yes, ankylosing spondylitis is also a systemic disease. Beside affecting the joints and bones, it affects other systems of the body. It can affect your eyes, it can affect the skin, it can affect the intestine, in the small and large intestine. It can have effect on your health of the bone, that is they can have osteoporosis. They are more prone to cardiovascular complications. So these complications should be looked into it. And if it is left untreated, what can it lead to? It can lead to disability, deformity, chronic pain, fatigue, and organ involvement, like kidney involvement can be very severe in the form of amyloidosis, and there is a lot of protein loss from urine. So the kidneys are affected in this way.
So yes, when we talk about chronic fatigue, there are a lot of people suffering from fibromyalgia, and they're not able to even diagnose it because nothing comes as such in the investigations, but their quality of life is severely affected and they can't perform in their daily life activities. And just as you said that a rheumatologist deals with the muscles, the joints and the conditions of pain, right? So what do you advise people suffering from chronic fibromyalgia, fatigue and pains and aches?
So fibromyalgia is very interesting condition because they have a lot of symptoms, but nothing come out in the tests. So all the tests are negative and they have chronic widespread pain. So best thing for them is exercise and daily lifestyle modification. So they should adopt daily exercise, daily walk. Stress management is very important in these patients because medications are given for the fibromyalgia, but they are effective when your will is to control these symptoms.
So, right. So the will is important. So these pregabalins and all of that, gabapentin, do they have a role? Do these
yes,
medicines play a role in fibromyalgia?
For fibromyalgia, we prescribe medications. If they are not responding to lifestyle modification and exercises and daily walk, we prescribe them pregabalin or we prescribe them duloxetine. There are certain medications which can be given. They have some role, and sometimes we give them for the timing and then gradually decrease so that the patient can be off from these medications.
Okay. Now you said that stress has a very important role, and we know that in conditions of stress the psoriatic attacks also become flares up, and then you have the inflammatory bowel disease flaring up as well, and as you mentioned ankylosing spondylitis or everything else is stress related. So do you think that meditation, reiki, some relaxation kind of techniques also help, and does a rheumatologist also prescribe some medications for the stress, for example antidepressants and serotonin intake inhibitors?
Okay. The stress is a key role in fibromyalgia and psoriasis, as you mentioned, inflammatory bowel disease, but mostly it doesn't have any role in other autoimmune diseases. But yes, the patient who have these chronic diseases, because all the rheumatic diseases are chronic diseases, and like rheumatoid arthritis, like SLE, so they have effect on the psyche of the patient. So they become fibromyalgic, they develop secondary fibromyalgia. So it is not the primary fibromyalgia, they develop fibromyalgia as a part of their disease because it is very chronic and affecting their quality of life. So yes, we sometimes when they have a secondary fibromyalgia, we give them for the time being pregabalins and treatment for their anxiety and
what
depression.
about these water exercises? They say that underwater exercises, because less force can be applied, they are very helpful. Swimming, so do you advise these to your patients?
Recent recommendations of the ankylosing spondylitis prefer land-based exercises as compared to aquatic exercises, because it's not easily available for every patient to go and for this pool or all these things.
That's true. So when we talk about, we eat a lot of meat, and most of us have this raised uric acid when we go for an RFT, and it presents with that big swollen toe, and gout is a very, very, very common condition. So how is gout different from any of these, and how do you address this big inflamed joint that people keep thinking is due to something else, whereas it is due to gout?
So, gout is different from all these diseases because it is the only single disease which is related to something which we eat.
Exactly, and the meat.
It is the only thing because the first thing when the patient is just leaving your office, they come back, डॉक्टर साहब आपने खाने को कुछ नहीं बताया कि क्या ना खाएं ना खाएं. So they ask about what they should eat or what they should not
avoid,
eat.
what they should be avoiding.
What should they avoid. This is the only disease which is caused by the alteration of the diet, because eating lot of proteins, lot of meat and dairy products, and they raise uric acid. So it is a common condition, but every raised uric acid doesn't need treatment until unless it causes a swollen joint, until it comes in a form of attack, like it attacks the joints and joint becomes swollen, inflamed, and it's difficult for you to walk, and you have to come to a doctor, either to a rheumatologist or medical specialist for the treatment. So this is, in this way it is different from other autoimmune diseases.
So firstly, that big inflamed toe, the inflammation needs to be brought down, and then secondly, what is the role of this allopurinol?
So when the patient of gout comes to you with a high uric acid, with a swollen tender joint, first of all you have to relieve the pain, make him mobile, and this inflammation settle within 1 to 2 weeks or 10 days or 2 weeks, it settles down. And then if the patient have more than 2 attacks in 1 year, you put them on uric acid lowering drug, which you mentioned, commonly known drug allopurinol or Zyloric.
But this is not for a long time, right? It is only till their uric acid gets controlled.
No, this is the misconception.
Oh, okay.
This is the misconception that patient, once it is like that, we rheumatologists are very careful in starting allopurinol until unless it meet the criteria that you have either you have 2 attacks of gout in 1 year, or either you have deranged kidney functions, or you have stones, or you have uric acid deposits in the skin that are called tophi, until unless 2 attacks. If there are 2 attacks, then you prescribe them allopurinol or other uric acid febuxostat lowering drug. Then you prescribe them for whole life, and you have to maintain the uric acid level below 6, so that to avoid the recurrent attacks. So they have to go for dietary modification throughout their life, and they have to be on uric acid lowering drugs. And it is a common practice that patient, they have attack, they use Zyloric or allopurinol for some duration, and then stop it, and then come back again with another attack.
Okay, there's another thing I've seen in patients, that you tell them not to have meat, so they start having a lot of pulses and dal, which are also a very great source of protein, and it leads also to more and more of this. So do you give them a very definitive diet plan where they have to avoid proteins in general?
Yes. Practically speaking, the animal protein is the rich source of purines, so as compared to the plant. So the mostly avoided food should be the meat, the dairy products, and the fish, seafoods are to be avoided, soft drinks to be avoided.
So only green leafy vegetables should be taken.
Green leafy vegetables and pulses, and
the other pulses, I think, not the dal, the wheat and the rice, I guess, right? The carbs.
They're carbs.
They would be better. They would be better. Okay. When we talk about an anti-inflammatory diet, what do you suggest? Omega-3 fatty acids or turmeric or ginger, do they play a role? Or what is a good anti-inflammatory diet where you tend to curb all the inflammation in your body?
Scientifically speaking, yes, there are few data and literature about the diets, but incorporating them into recommendation is still not there, that there is no as such anti-inflammatory diet, but there are some
don't they say that a good Mediterranean diet that avoids a lot of carbs and refined carbs and sugars and processed meat is an ideal diet for inflammation?
Yes, it is said that, but our societies still not recommend any specific diet that to avoid. The only diet we say, the only disease which is related to diet is the gout or hypertension or diabetes or other diseases.
So when we say a rheumatologist deals with rheumatic diseases, and it falls like rheumatoid arthritis also comes in it, there is rheumatic fever that involves the heart and an infection. So does that also fall under your domain, or it's just a name?
No, it doesn't fall under our domain. Rheumatic fever, yes, rheumatic fever, that is one. You have acute rheumatic fever in which your heart valves are damaged, you have fever, you have skin lesions, and you have inflamed joints. That is acute rheumatic fever. Yes, it comes under the domain of rheumatology.
But when it complicates and involves the heart, then it becomes a problem.
When it complicates and involves the heart and it become chronic involvement
So
of
could
the
you
heart.
just mention the symptoms of a rheumatic fever again, because many children after having a dental infection, a dental procedure, tend to catch this infection and then they have rheumatic fever, so they know that they need to get it treated right in time.
So the rheumatic fever is a disease which affects usually the younger, the children between the age of 5 to 15 years, and usually it is preceded by a streptococcal sore throat or infection, and it usually they present with a fever, with the heart valve involvement, or with the prolongation of the PR interval, which is seen on the ECG. They have their some skin lesions, and in addition to that they have their swollen joints. They have arthritis, they have tender swollen joints.
And this can be treated via the antibiotics?
This can be treated with the antibiotics, and if we need to test the ASO titers, or we need to take the throat swab for the diagnosis. But it is also a common practice that every patient who have the joint pain come with ASOT, हमारा तो ASOT positive आ गया, we have this ASOT positive, not treat us. So every joint pain is not a rheumatic fever. So it is usually seen that the patient who come from the periphery, they have their ASOT done, and they have their uric acid done. And beside that, their disease is not related to both of these conditions. So this acute rheumatic fever is an acute condition in which arthritis settles within the 6 week and doesn't go beyond 6 week. If the patient have arthritis beyond 6 week, then this is not the rheumatic fever.
What about vasculitis, different kind of inflammation of the vessels, or does it also fall under it, because we had a number of diseases that fall under vasculitis, they are also autoimmune conditions. Do they fall under rheumatology?
Yes, vasculitis is very much a part of rheumatology, and it covers I think most part of the rheumatology. It affects the vessels. When there is inflammation of the blood vessels, they can manifest in different way. You can have the loss of blood supply to digits or to some other area of the body. Wherever the vessel is affected, that part or that organ shows its manifestation. If it is affecting the heart, then it will affect the cardiac symptoms. If it is affecting the brain or eye, then you have eye symptoms. If it is affecting the skin, then you have skin symptoms. So it depends upon which size of the vessel is involved. Either it is the small vessel, or is a big vessel, or it is involvement of the major vessel, that is aorta or its branches.
And this is also dealt with disease modifying drugs?
With the steroids, basically acute phase is controlled with the steroids, with their life saving and organ saving medications. I would try to give a message that don't be scared of steroid when you are consulting a rheumatologist, because the rheumatologist, I think, the safest doctor to deal with the steroids, and they give steroid very carefully, and so the steroids are life saving and organ saving.
Thank you so much, Dr. Uzma Rasheed, for joining us today. You gave us a very detailed description and explained to all our viewers what they need to do regarding rheumatological diseases. And if any of you faces any of these symptoms, please don't hesitate in contacting a rheumatologist. And we have now, even if there are few, we have a few notable ones like Dr. Uzma present in our twin cities, and you can actually consult them. And then don't feel scared of taking the medication that they are giving you, whether it's biologics or steroids, because the doctor knows and weighs the benefit over the risk. Thank you so much for watching. Inshallah, we'll meet you next week. Allah Hafiz.